Hello AS, welcome to your final flip learning for the biological explanations and treatments of OCD. This is the last thing you will do on psychopathology. So let's get straight to it. If we start with looking at the biological explanations, a lot of this isn't, some elements of this aren't new to you. Hopefully you'll be familiar with some of the things. However, they do ask for genetic and neural explanations of OCD. So the genetic ones, the genes that potentially cause OCD. We do call it polygenetic, so more than one gene is involved in the process. However, one of the genes that we do look at is the COMT gene, which is involved in the production of levels of dopamine and controlling the levels of dopamine. And it has been found that people with a faulty form of the COMT gene generally do have OCD. And then what it is the COMT gene is the activity is lowered, and because there is low COMT activity because of the faulty COMT gene, then there are increased levels of dopamine. Okay, faulty gene, lower COMT activity, and therefore increased dopamine. There is also the SERT gene, which is linked to serotonin, and a fault in this gene leads to problems with the reuptake of serotonin, reducing the levels of serotonin available in the synaptic cleft. So you know about the reuptake of serotonin, or any neurotransmitter, of which serotonin is. A fault in the SERT gene affects the reuptake of serotonin, reducing the amount of the serotonin that is available in the synaptic gap. And they do find that 6 out of 7 family members do have, or there are a large number of family members that do have faults in the SERT gene if there is OCD in the family. And then finally, something to bear in mind, the genetic explanation, there is the diathesis stress model, which we've come across before, which is the idea that we have both a genetic vulnerability to OCD, but we also need alongside that the correct environmental triggers. So we would need the faulty COMT gene, or you'd need the faulty SERT gene, but as well as that, we would need environmental triggers that would lead to OCD as well. It's unlikely that absolutely everybody who's born with that faulty gene will develop OCD. They need those environmental, those external triggers. So think nature, genetics, nurture, environment. It's a combination and interaction between the two. We've then got the neural explanation, so they could ask specifically for the neural explanation, or we'd have to talk about these things, or they could ask for the biological explanation, where you could discuss the genetic explanation that we've just discussed previously, and then also the neural explanation, which we're just about to discuss. So neuro, as you know, means brain, and we're going to talk about the chemicals in the brain. So the neural explanation for OCD is there are abnormal levels of neurotransmitters in the brain, and we have found there's high levels of dopamine, which is related to the COMT gene. So low levels, faulty COMT gene, low levels of COMT activity, and therefore increased levels of dopamine. And there has been research by Schätzman to suggest that if they increase the levels of dopamine in animals, if they inject animals with dopamine, increase the levels of dopamine in animals, they do find there are very repetitive movements. And as you know, one of the characteristics of OCD is very repetitive movements, those compulsive behaviours that they can't control. So it would suggest that there is a causal relationship, cause and effect in animals. Increased dopamine leads to increased OCD symptoms, although of course you could also talk about issues with extrapolation, but we'll save that for AO3. And there are low levels of serotonin, and that is caused by the faulty SERT gene, which is involved in the reuptake of serotonin. Research has found that antidepressants which increase serotonin levels have been found to reduce the levels of OCD. So antidepressants that we're going to have a look at in a minute, the treatments that specifically target serotonin and increase the levels of serotonin have been found to reduce the symptoms of OCD, suggesting that serotonin is involved. And antidepressants that do not target serotonin do not appear to reduce the symptoms, suggesting that it is specifically serotonin and not other activities, not other things within antidepressants that reduce the OCD symptoms. So it's almost like having a placebo effect. You've got or a control group with the antidepressants. Okay, and there's also abnormal brain circuitry which fits under the neural explanation as well, so abnormal structure or the way that the brain works. So in someone without OCD, there is a part of the brain called the OFC which sends signals to the thalamus. The caudate nucleus suppresses those signals from the OFC if they are unimportant or not sensible. So the OFC sends warning signals to the thalamus, but they are suppressed by the caudate nucleus if they are unimportant things that the brain doesn't need to worry about at all. So the OFC is saying, oh, panic about everything to the thalamus. Imagine him shouting across the room to the thalamus, panic, panic, and the caudate nucleus is in the middle going, it's absolutely fine, thalamus, you don't need to worry, it's not a big deal at all, you've just lost your car keys, nothing terrible is going to happen, you're not in danger. Someone with OCD, however, the caudate nucleus is damaged, and therefore, when the OFC sends those panic signals to the thalamus, when it's shouting at the thalamus across the room, panic, panic, there's nobody standing there saying, don't worry, it's fine, calm down, nothing will happen. And the thalamus and the body believe that terrible and dangerous things are going to happen to them. They feel very, very much at threat. And this is linked to and can explain those obsessive thoughts that somebody with an OCD might have, because they cannot control the caudate nucleus, which would regulate and monitor those thoughts. So they don't make it to the thalamus, so the thalamus doesn't start to panic, aren't controlled for, and therefore it doesn't explain those obsessive thoughts. The OFC, which is part of the brain, is also linked to serotonin. So brain scans have found heightened activity in the OFC of OCD patients when experiencing obsessive thoughts. So first of all, we can link that together. So we can see that the OFC is clearly involved in the process of explaining obsessive thoughts, supporting that idea. And we've found that serotonin in neurotypical people's brain, people without OCD's brain, serotonin regulates the function of the OFC, which of course the serotonin is much lower. So not only is the caudate nucleus not working in somebody with OCD, but the OFC is not functioning correctly either, because there is too low levels of serotonin. By increasing those levels of serotonin, we'd improve the function of the OFC, which might explain why the OFC doesn't send as many worry signals to the thalamus. Okay, and the OFC is also found to have been linked with dopamine. So dopamine is involved in functioning in the frontal lobe, and the OFC is found in the frontal lobe, and it has been found that high levels of dopamine can lead to overactivity. So serotonin is not helping the OFC function effectively, and dopamine is making the OFC overactive, so sending too many worry signals to the thalamus, and because the caudate nucleus is damaged, is not working, then it can't regulate and control those obsessive thoughts. Okay, evaluation, PICs, practical applications, SSRIs. Please have a look for those after the treatments. So leave this one blank and return to it. The example is the SSRIs. You need to think of a beginning sentence for it, and you need to tell me about practical applications, whether they're good or not, and then also why they are good or not. So you know the P structure, you know the deal by now. Issues and debates. It is the biological explanation is very, very deterministic. So this is the idea. Determinism is the idea that we don't have any free will. We don't have any self-control. We don't decide what happens to us because of various internal and external factors. And in the case of the biological approach, it's internal factors. Certain things will happen, and there is no control over them. For example, if you have low levels of serotonin, or you have high levels of dopamine, or you have certain structural issues with your brain, your OFC or your caudate nucleus isn't working properly, then it will lead to you having OCD, which of course is a problem, because it's telling people with OCD they have no control over their symptoms, which does potentially leave them feeling very vulnerable and very lost and without ability. Of course, it's never appropriate to tell somebody that they should be able to control. You should be able to just control your mental health needs altogether. But to remove that control altogether obviously causes problems, and it also ignores the fact that people are able to manage their obsessive thought processes through some self-control, some free will, which they can choose to do. So it can't explain all forms of OCD, because people are, with treatment, able to control them, which is something that the biological approach, which is biologically determinist, cannot explain. We've also got contrast to alternatives. Please bear in mind, issues and debates and contrast to alternatives, you do not use that phrasing in the P structure. You reword it to explain it. So an alternative explanation for OCD is the two-process model, and there is more information on Moodle about this. However, you know about the two-process model, so the suggestion is that we can acquire OCD through classical conditioning, and Mary had an aunt who had cancer. Mary was very, very scared of was worried about cancer and found it very difficult to spend time with her aunt. The neutral stimulus was the chair that Mary's aunt sat in. And then eventually she learnt to associate illness, so the cancer, with different parts of furniture, and she developed a fear of that. And then through stimulus generalization, she also then began to generalize to other people who sat in the chair, other pieces of furniture, and soon she began to develop a phobia, and that's possibly how a germ phobia has developed. And then the key one that I think is more significant, that I talk about in more detail, is negative reinforcement. And this can quite clearly explain OCD. So one sec, let me change one thing about this. There we go. See if you spot what I've changed. Negative reinforcement really works really effectively, as you know. So the people will probably feel incredibly anxious because they've developed this fear, this phobia, this worry about whatever it might be, and then they've found that there are certain behaviours that calm that anxiety. So those behaviours remove that stimulus of anxiety, that worry, and therefore they increase the activity of those behaviours increases. And they could be things like washing your hands, they could be things like turning on and off the lights, they could be things like tapping the wall so many times, and they are the compulsive behaviours, and those compulsive behaviours increase and develop because of negative reinforcement. So there are alternative ways that are just as effective, explanations that are just as effective to explaining OCD. However, a saving grace of the biological approach is supporting evidence, and you should be familiar with Billett and Lestrade because we've looked at those before in the biological approach, so hopefully you can see that I'm trying to save you time and effort. They found it's 2 times more likely for an MZ twin to develop, so there's 2 times highest concordance rate for MZ twins to develop OCD if one of their twins has their twin has OCD compared to DZ twins. So you are more likely to develop OCD if you are an MZ twin whose twin has OCD than a DZ twin. As we know, MZ twins share 100% of their DNA, whereas DZ twins only share 50% of their DNA. And Lestrade, who found that you're 5 times more likely to develop OCD if you have a first-degree relative with OCD compared to the general population, suggesting that there must be some genetic or inherited forces such as the COMT or the SERT gene, or damage to the caudate nucleus, or whatever it might be that causes OCD. It suggests that it is heritable. There is some genetic factor. And then we'll go into the treatments. Treatments, really nice and easy. You need to practice how to structure them, but ultimately the information isn't new. So we have here, I hope you can all recognise, the diagram for synaptic transmission. So you have, and what I would encourage you to do now is pause the video and perhaps have a go at remembering as much of the process as you can. There were some really good answers from previous assessments we've done, but it's definitely one that's worth checking. So see what you can do. Do a little bit of revision here. So SSRIs, selective serotonin reuptake inhibitors. So they inhibit the reuptake of serotonin, which of course leaves more serotonin in the synaptic gap. And the way they do this, as you know, reuptake happens through the transporters, is the SSRIs block the transporters, so they cannot reabsorb the serotonin, and therefore there's more serotonin in the synaptic gap, more serotonin available. So let's go through the step-by-step process. You would take an SSRI and it blocks the reuptake of serotonin. It blocks the transporters, therefore the serotonin cannot be reabsorbed. Therefore there's more serotonin in the synaptic cleft, which is more likely to bind to the receptors on the postsynaptic neuron and therefore have the desired effect on the postsynaptic neuron. And then of course, because as we know there's more serotonin, this reduces levels of activity in the OFC, because we did talk about parts of the brain. So one of the things it's linked to could be the idea that it reduces levels of activity in the OFC. It helps the OFC function more effectively, which is part of the brain that we looked at. And then it also, which then also allows us to block the signals to the thalamus are less likely to get through and more likely to be blocked as well. Okay, reducing the symptoms of OCD. There are some types of SSRIs that you could have a look at, and you can have a look at tricyclics in a little bit more detail. But ultimately that it is, we've worked so hard on synaptic transmission. As long as you're confident with that, the SSRI should be fairly easy to explain. However, if you're not confident on synaptic transmission, now is your time to go back over and look at it. And then finally, the evaluations. As always, you know the evaluation is a REST. Relapse rate. So we've got Baitlin, 2017, who conducted a meta-analysis and found that there is up to a 20% relapse rate of people who take SSRIs who have OCD, and you can decide whether you think that's a strength or a weakness. And it would be an excellent opportunity to include a however sentence. If you said it was a strength because it was a low relapse rate, then you could talk, then you could say, however, there is still a relapse rate, or you could say it's a weakness because there is a relapse rate, however, it is a fairly low relapse rate, or it's still not everybody relapses. And then of course Sumra, which you have already seen before from 2008, found that SSRIs were more effective than a placebo. However, they did also find that there were many more side effects to a placebo. So that's again something to consider with the howevers. There are a huge number of various and extensive side effects, and I have linked the NHS website to Moodle. I would like you to have a look, or you can Google it. You can have a look there. Just Google it in general, or have a look on the Moodle link and make a note, please, because I'm going to ask you about some of the side effects. So please make sure you've got some of the side effects noted down. And then the time taken, it's incredibly quick to administer drugs, and they are fairly inexpensive as well. So you could go to the doctors and be administered them that day and go and pick them up from the pharmacy, and they wouldn't cost a huge amount to the NHS. They're fairly inexpensive to manufacture, which is what you could talk about. However, it has been found that it can take up from 10 to 12 weeks for SSRIs, or for people to respond to SSRIs, or the symptoms of OCD to respond to SSRIs. So the administration can be effective and inexpensive in comparison to treatments. They can happen quite quickly, but it can take a while, because of course it's possible potentially that the body's got to build up the levels of serotonin that are available, or the SSRIs need to take time to work. Okay, please work hard on at home structuring the evaluation points. I don't give you the evaluation points because in the exam you won't have them. I want to reduce the amount that you have to remember to the absolute minimum. So if you were asked this question, hopefully you'd write REST on the paper, you'd be able to write back Baitlin, Sumru, various, and quick, and then from that, because you've practiced this skill so many times, you would be able to structure the evaluation points: point, example, explain. So it is really important that you keep practicing these evaluation points rather than having to memorize them off by heart. Just learn the prompts, and then the skill is in writing and structuring them. Okay, thank you very much. Well done for surviving psychopathology.